So, good evening, Avishek sir. Good evening, Akash sir. So, today's topic is acute liver failure, and the speaker we have here is Dr. Avishek Roy, who is Associate Consultant in ICU Apollo Multispeciality Hospital, Kolkata. And the moderators we have here is Dr. Akash Roy, who is Associate Professor and Consultant at Hepatologist and Liver Transplant Physician at Apollo Hospital, Kolkata. Thank you. Sir, you may start.
Good evening, everyone, and my warm regards to Dr. Akash. He is a well-known figure in this field. So I'll be presenting this topic with the perspective of ICU specific care, and I definitely know that Sir will have some important points to add over and above this. So the overview of my topic includes this following head points. So definition, etiology, epidemiology. Then I'll discuss the clinical features, major investigations, and important organ-specific management points. So coming to the most important part, definition. So definition of acute liver failure starts with an acute derangement with liver function characterized by deranged INR or the PT. INR more than 1.5 is the threshold, and along with start of hepatic encephalopathy or altered sensorium in loose terms, but mostly hepatic encephalopathy within a preset number of days after the onset of jaundice. So a patient having all the three, jaundice, coagulopathy, and hepatic encephalopathy, all the three has to be there to call it an acute liver failure. And the duration from the start of jaundice till the onset of encephalopathy is different as mentioned in different societies. For example, in American Association of Study of Liver Disease, it mentions as less than 26 weeks to be as acute, whereas the European Society mentions less than 7 days to be hyperacute. Acute is 8 to 28 days, and subacute is 5 to 12 days. The Indian Association mentions this is Indian Association of Study, that was the previous guideline. The current INASL guideline 2020 mentions as acute being less than 28 days. So this is the most important thing that we have to remember being an Indian intensivist and hepatologist. This is that less than 4 weeks of onset of jaundice, we call it acute liver failure. So this classification historically has been based on different papers. Like there are different grading systems like O-grade system, Burnau system, the Japanese classification. Indian is kind of an amalgamation of mostly the Japanese with an O-grade system. So we call it acute less than 4 weeks. From 4 to 12, we call it subacute. And the fulminant thing is not so much used. So the reason is that I have mentioned this. I think here I have mentioned. So this one is what is currently been mentioned in the INSL guidelines, that acute liver failure is when we have all the three. So we'll have coagulopathy, jaundice, and hepatic encephalopathy. If you have the first two, that is, you have coagulopathy and jaundice, but you don't have a liver hepatic encephalopathy, we call it severe acute liver injury. And if you have ascites after the jaundice, but there is not much of an encephalopathy, a picture which is in between an acute liver failure and a decompensated chronic liver disease, we call it subacute liver failure. And the chronic liver failure is whenever you get the chronic liver failure stigmata, usually the timeline is more than 6 months. And acute and chronic is a different terminology. Today's discussion is not on this, so I will not discuss those. Now coming to the etiologies, very important. So the most common etiology in Indian perspective wise is viruses, and the most common virus causing are hepatotropic virus, that is most commonly the hepatitis A, hepatitis E, hepatitis D. Hepatitis B flare is also very common. Hepatitis C is not so common as an acute cause, but very, very rarely it can cause. Other than that, we have to remember that some other viruses like an acute cytomegaloviral infection, Epstein-Barr virus infection, reactivation of herpes simplex virus, all these are important causes, especially in immunocompromised patients. These are all, this can be found. Other than that, we know that toxins are also very common cause, drugs and toxins. Other than the viruses, the second most common cause of liver failure in India is drugs. Among the drugs, anti-tubercular drugs, anti-malarial drugs, antiretroviral drugs are very common in India. Sulfur drugs and all are obviously common. Paracetamol in the West is the most common, but in India, paracetamol is very lesser common cause of acute liver failure. We have to remember that among the toxins, although carbon tetrachloride and all are mostly historic, it's mentioned, but more common, more commonly we see is that mushroom poisoning because of Amanita phyloides. Sometimes the yellow phosphorus kind of poisoning, zinc phosphide poisoning can cause an acute liver failure. And the several or the various other causes include Budd-Chiari syndrome, Wilson's, AFLP, that is acute fatty liver of pregnancy, autoimmune hepatitis, Reese syndrome in children, and sometimes the third most common cause in acute liver failure in Indian scenario is in many centers is a cryptogenic cause where we don't find any identifiable cause. And in an upcoming etiology, herbs, most commonly use different types of herbs which are used by Ayush practitioners but have been implicated in causing different forms of hepatitis ranging from massive hepatic necrosis to an autoimmune kind of picture. Especially during COVID pandemic, the use of giloy was associated with acute liver failure. Now, the other causes, like for example, in our climate, dengue, scrub typhus are also very common cause of liver failure. So these are also very commonly should be sought out for. Alcohol does not cause acute liver failure. It can cause either CLT or an acute or chronic liver failure or an alcoholic hepatitis. Other than that, ischemic hepatitis is also a very common cause, although it doesn't per se cause failure, it causes severe acute liver injury. Causes are various. And then, as I discussed previously, in pregnancy related cases, acute liver failure of pregnancy and preeclampsia HELLP syndrome are the differentials. Now, this is a trivia question that in what conditions that we see that patients are having marked as cirrhosis or CLD, but still we can mark them as acute liver failure and not acute or chronic liver failure. These are three conditions as mentioned in INSL. That is Wilson's disease, vertically acquired hepatitis B infection, not sexually transmitted. If it is a congenital kind of infection, vertically transmitted, and autoimmune hepatitis. So these are the areas where, despite being CLD, the flares are marked as acute liver failure. So that completes the initial part of the etiologies of the liver failure. Now coming to some of the clues which can point towards a specific etiology. For example, I'm not quoting individual details, but some clues. For example, in an adolescent patient, equal predominance of male is to female, probably some neuropsychiatric history can be or cannot be present, but an acute onset of liver dysfunction and altered sensorium, and especially the presence of KF ring, Kaiser-Fleischer ring, suggests a possibility of a Wilson's disease. The other diagnostic clues of Wilson's are autoimmune hemolytic anemia, which is Coombs test negative. Along with that, we have a high bilirubin is to alkaline phosphatase score, a very common score used in this system, that you get the bilirubin is very high, but the alkaline phosphatase is drastically low. The ratio is usually 1:4. Other important etiologies, when you see AST is disproportionately elevated as compared to ALT. Although this pattern can be seen in various vascular cause as well as alcoholism. So this is not specific. However, these are all pointers. Diagnosis can be done by ceruloplasmin level, although it can be falsely elevated in patients with acute liver failure and acute presentation. Other than that, serum copper level, urinary copper excretion, and liver mass per gram of tissue of copper are diagnostic points. Each and everything has its own drawbacks. I'll not discuss those in details. So Wilson's. Second, another important, not second person, another important or less or not so common cause is yellow phosphorus poisoning. We get it in the form of rat killers, pesticides. They are very commonly bound to sulfhydryl group, causing protein denaturation, causing different organ damage. Along with liver failure, they can cause severe cardiac, renal compromise. So the presentation is almost like an ALF kind of a thing. Obviously, we'll get a history of ingestion of unknown substance. Now, the other common thing which presents with an acute, which can present, it's Budd-Chiari syndrome. But my foremost work about is that it is a less common cause. Only less than 5% cases of Budd-Chiari presents with ALF. Most of the time, it causes CLD, so it's a chronic presentation. However, in acute stage, if there is a simultaneous obstruction syndrome, it is a either the thrombotic or a stenotic occlusion of the hepatic venous outflows. What are the hepatic venous outflows? The three hepatic veins that drain into the IVC. So anywhere up downstream from the liver towards the IVC, there is an obstruction. The most common cause being a hypercoagulable state, which in our country is polycythemia. It could be protein CS deficiency, malignancy like pancreatic cancer, even liver mass, etc. Sometimes amoebic liver cyst or hydatid cyst, they can compress the hepatic outflow tract, not particularly causing a in within the lumen obstruction, but causing an out of the lumen obstruction. And in West, the most common cause is mostly an IVC web, which is mostly congenital in origin. So presentation like an acute right upper quadrant pain, like a liver abscess type presentation, hepatomegaly, raised enzymes. Diagnosis is done by ultrasound along with portal Doppler, and we can do a CECT angio. The primary therapy or the first line therapy is therapeutic anticoagulation. Look out for the procoagulant factors that are causing it, and call an intervention radiologist for causing an endovascular therapy. Recently, TIPS has found a great role in managing Budd-Chiari syndrome. So when you can't recanalize, you create a shunt, you create a portosystemic shunt. That's what is TIPS is. So TIPS has a very good role in Budd-Chiari syndrome. Other than that, autoimmune hepatitis, yes, it is again a cause kind of a bimodal kind of distribution. The commonest antigen or antibodies which are looked out for is anti-SMA, anti-smooth muscle antibody, and anti-LKM. Anti-LKM is liver kidney molecule. So against those, we try to find the antibodies. However, there are various antibodies mentioned like ANA, ANCA, different antibodies come in positivity in different routes, and higher immunoglobulin levels or a positive test does not per se always tell you that it's an autoimmune cause. So there are various false positives and false negatives, both in autoimmune causes. The steroids are given generally in the acute autoimmune hepatitis form. There is some role of steroids, but when it's a frank liver failure form, it doesn't have that much amount of role. Other than that, very rare causes like malignant infiltration, and as I said previously, in our country, dengue and scrub typhus has to be thought for. So ALF mimickers, it's not per se called ALF mimickers. They can cause ALF also, but typhoid, severe typhoid infection, rickettsial disease like scrub typhus and all, leptospirosis, dengue, they are all ALF mimickers. Now coming to the pathology, a small description. So it is mentioned in INSL that the one of the pathognomonic features of ALF is a cell dropout. There is a decrease in the number of the hepatocytes surrounding the centrilobular nodule, centrilobular lobes. Along with that, there can be, if the insult is too acute and fulminant, there can be massive hepatic necrosis. And along with that, it's a pro-inflammatory state. You get all the pro-inflammatory cascades, the DAMs. DAMs means the damage-associated molecular patterns in the form of inflammatory mediators, cytokines. They cause a lot of steatosis, damage to the structural structures, and causing necrosis, centrilobular necrosis. All those things can be seen. Epidemiology, it is a bit kind of confusing slide. However, most common, as I said, in India is an hepatotropic viruses. If we talk about pregnancy, then hepatitis E is a very common cause. Non-A, non-B causes and cryptogenic causes are also very common when we don't find any etiology. And as I said, that herbs and different other alternative medicines are coming up as a cause of this. And in India, drugs most commonly implicated in ALF is acute anti-tubercular therapies. Now coming to the next part, that is how we approach a patient. So we first look at the patient, we stabilize the patient to take a history. Simultaneously, we have to apply the ABCD approach. We stabilize the airway, breathing, circulation, assess the volume status. If need intubation, I'll come later when intubation is required. So we have to go for intubation, secure lines, call for the coagulation factors, call for blood grouping and cross matching, send the labs for the evaluation, and then comes the organ specific management. So clinical features which point towards the liver etiology can be very misdirectional in a way that patients can have very minimal symptoms. They can say, okay, patient had some fever, then patient had some altered sensorium. We don't know exactly what is happening. Some abdominal discomfort. So your clinical features, because of the acuteness, can be absent in many of the times. Even if you can have features like fatigue, malaise, anorexia, nausea, vomiting, right upper abdominal pain, pruritus because of bile acid accumulation, jaundice, etc. can be found. And not so common, but many times in acute liver failure, causes of acute liver failure can have a simultaneous effect on the pancreas. So always look out for if there is a pancreatic involvement when you have a liver dysfunction. especially when it is acute or toxin mediated. Now, coming to the lab investigations, the very commonly sent, other than the routine labs like the CBC, KFT, LFT, we have to look out for the coagulation markers like the PT and the INR. The international normalized ratio, the INSL recommends to be checked 12 hourly, and so that's 2 times a day.
Yes,
It has a
children.
prognostic value, also helps to decide upon what way the patient is going. So this is a very important test that if you have to single out one test that you have to do in order to diagnose the stage of the liver disease, it is INR. Other than that, you have to do the QDA, creatinine, blood grouping cross matches, the ABG for looking at the lactate, because lactates are elevated because of multiple reasons like hypoperfusion, also type B lactic acidosis, where you have decreased excretion because the liver functions is not acute, not perfect. So all these things causes raised lactate. Now etiology specific, we send the hepatitis panel that is causing, that is having all these hepatitis, anti-HIV, IgM, hepatitis surface antigen, anti-HCV, like anti-H core antigen of hepatitis B, HCV RNA assay, and hepatitis E RNA. So all these things comes under the common test known as hepatitis panel. Then we send the routinely as the situation demands. If we have to send for paracetamol drug levels, and we can go for toxin levels. If we suspect Wilson's, we send the ceruloplasmin level, and so and so. And if we suspect dengue, we send the dengue markers, scrub typhus test for that. So it depends. But whenever a patient like this comes and your initial test for hepatitis is negative, then you have to send all the panel or all the array of causative factors as soon as possible, because these patients don't give you time, they deteriorate very rapidly. So do not waste time, in deciding upon which test to send in third day or fourth day. The patient might not live till that day. So send all the positive possible causes or causative investigations as soon as possible. Role of liver biopsy in ALF, very doubtful. INSL doesn't recommend, only in cases where you can't really diagnose a patient, like hemochromatosis or some rare form of storage disorders. So in those cases, probably you can go for a liver biopsy or some malignant infiltration, etc. However, in most of the cases, it is not done, not so commonly done. This one I have already mentioned, that what to monitor. So that depends on the organ system involvement, and lab parameters I have already mentioned. I'll move on to the complications of acute liver failure. Now, this comes the most important parts and the areas to manage. So, the important complications are, first of all, it's cerebral edema. Second is plus minus seizures. Then you have infections, coagulopathy, particular set of respiratory problems, hemodynamic problems, and AKI renal failure. So these are the main complications that we deal with. And the first and foremost complications that we have to discuss in details, it can be asked in various forms, as well as it can be asked in exams, multiple choice questions, however. So the first complication is hepatic encephalopathy, or you can loosely term it as cerebral edema. Sorry. So this is a diagnosis of exclusion. However, it is very commonly present. If you have an ALF patient, around 50 to 60% cases have a diagnosis of hepatic encephalopathy at onset. Very important to remember that this hepatic encephalopathy of acute liver failure and that of a chronic liver disease are different. So the etiology, the markers, and the presentation wise also is different. Here, cerebral edema is very, very prominent. In chronic liver disease, cerebral edema is not so prominent. So here, the pathophysiology is more of a cerebral edema. We have to treat and manage the cerebral edema very fast. And the role of ammonia is there, but it's guarded. It's not a sole mechanism of cerebral edema. So the role of anti-ammoniacal measures is less in patients with hepatic encephalopathy due to an acute liver failure, the classical anti-ammoniacal measures. So mortality obviously is bound to increase with presence of cerebral edema. 58% population can have cerebral edema. Classically, we measure cerebral, or we address the stages of cerebral edema by the Westhaven criteria, which has got 4 stages. Stage 1, you can read up on yourself. Stage 1, 2, 4, 3, 4. Mental slowness, euphoria is stage 1. Stage 2 is lethargy, apathy. Stage 3 is coist to a stuporous stage, and stage 4 is coma. Now, there is a trick that I follow in my real time, in my real life. I don't know whether it's right or wrong. If you have difficulty in finding a patient or diagnosing a patient with hepatic encephalopathy, that is grade 1. If you are sure that, okay, there is some altered sensorium, there is some delirious kind of picture, but not so stuporous or comatose, it's 2. And if the patient is either stuporous, means, extremely drowsy but still on deep stimulus, some stimuli is there, and completely comatose, the patient is 3 or 4. Either way, it doesn't matter. If the patient is 3 or 4, its management is 3 or 4 types. If the patient is 1 and 2, management is that type. So the drastic difference is why it is important is that if the patient is having a higher grade 3 or 4, you might have to intubate, you might have to aggressively treat the cerebral edema. And if the patient having grade 1 or 2, probably close monitoring is enough. So that is how a quick trick for diagnosing hepatic encephalopathy. There are other criteria like the Rigler's and the Lake's criteria for diagnosing hepatic encephalopathy is almost as similar as possible. One beautiful thing about that I learned after I passed DM is that the way hepatic encephalopathy progresses, like from an agitation, delirious kind of a stage to a complete comatose stage, when they improve, they will also go back in the same manner. And so that when there is an improvement, there is also a stage where from comatose they come back to an hepatic stage encephalopathy 2 or 1, where you can have some amount of agitation. We don't have to take it that it's a deterioration. Actually, that's an improvement because they're coming back from a greater stage. Now, coming to the role of ammonia and the role of glutamine. Why is ammonia is so much feared in liver failure? Is that the ammonia is accumulated because of the non-clearance, the urea cycle, which is the major cycle for eliminating sodium ammonia from our body, is defective because of the liver dysfunction. Now the ammonia builds up in our body, the blood, especially the gut, where different bad bacteria especially protease producing bacteria break up the proteins, create ammonia, and the ammonia go into the blood. They are not metabolized, so they go into the brain. Once they go into the brain, they join with glutamate to form glutamine by the enzyme glutamine synthase. The problem is that this glutamine is kind of a large molecule. It accumulates water, and now it basically it stays within the astrocytes. Astrocytes are the supportive structures of our brain, and they cause cerebral edema because the astrocytes undergo swelling. So this is one mechanism. Other than that, also it blocks the glutamine from the astrocytes. It increases synaptic glutamine formation. So, and also it kind of reduces the excitatory neurotransmitters and thereby causing a kind of relative excess of the inhibitory neurotransmitters. So ammonia is one of the key mechanism, and glutamine accumulation in the astrocytes causing astrocyte swelling and thereby cerebral edema. There is another mechanism, all those hypotheses, is Trojan horse hypothesis. Trojan horse is a mythological character, not mythological, real character described in the War of Troy, where a particular group of people were they entered into a hidden area by virtue of hiding inside a wooden horse. So when something hides within some other thing and then creates its own pathway, it calls it a Trojan horse. So the ammonium, they enter the astrocytes and they enter the mitochondria by virtue of MPT, mitochondrial permeability transporter, and then they cause the mitochondrial dysfunction, causing ATP depletion and all those. So that takes the pathway of a normal thing, but it creates an entry into the mitochondrium. So that's why it's a Trojan horse hypothesis. So in nutshell, it causes the reactive oxygen and nitrogen species formation. All these things causes mitochondrial damage. When you have no mitochondria, you have ATP depletion, you have necrosis. So there is another thing which has to be important other than ammonia and all those is vasogenic edema. So vasogenic edema is when you have a permeability edema, when you have increase in the gap junctions within the cells, the connective cells, and therefore from the vessels, the fluid kind of seep out and causing edema. Mostly it's implicated in different tumors or cancers in the brain. Here what happens is because of the increased sepsis and inflammatory mediators, there is increased EGF, that is epithelial growth factor promotion, and that causes vascular dilatation and causing cerebral edema. So the role of ammonia is multifactorial. So it causes increased glutamine in the astrocytes, causing swelling. It reduces the excitatory neurotransmitters, but it increases the harmful neurotransmitters, causing neurotoxicity like the glycine, and that causes instead some seizures and all. And it also causes an kind of an anti-infect immunity suppressive kind of an effect, causing neutrophil suppression by virtue of neutrophil suppression, increases chance of infection. GABA is also an important mediator for this, where you increase the GABA and GABA receptor binding, that also increases the somnolence as well as the effect of inhibitory neurotransmitters, and that's why there is some role of flumazenil, which is a benzodiazepine antidote. In some cases or some reports, some series also is there, flumazenil has been used in hepatic encephalopathy. So all these things, all these multifactorial things, the ammonia, the GABA, the other inflammatory mediators, the manganese, all these things causes intracranial hypertension. And as we all know that after a certain stage, when inside intracranial pressure increases and it follows the Monroe-Kelly doctrine, so after say 20 millimeters of mercury, there is an acute surge in ICP, and there is an acute drop in cerebral blood flow causing cerebral ischemia. So that is not tolerated well. So the intracranial hypertension is by either vasogenic origin, as I said, because of the increased vascular permeability, or it could be because of cellular damage causing a cytotoxic edema, causing astrocyte swelling. Now, coming to the other factors, as I mentioned, other than the above mentioned, mercaptans, glutamate, and other contributory factors like dysglycemia, hypoglycemia, hyponatremia, hypokalemia, all these things are also contributory. And that's why, again, to underline what I said previously, the cerebral edema or hepatic encephalopathy of an acute liver failure is multifactorial, and it is associated more with cerebral edema. That's why the ammonia lowering measures like rifaximin, lactulose has absolutely no role or very limited role in patients with acute liver failure. Now, can we detect an intracranial hypertension very commonly in our setup? Yes, we can do it by Cushing's triad, that is bradypnea, hypertension, and bradycardia. But when a patient has a Cushing's triad, that is quite advanced stage, that is kind of just before the herniation, cerebral herniation, and death. So before that, there is certain drop in the sensorium, any kind of seizures, anisocoria that should be looked out for. Along with that, we can have some monitoring techniques. What are the monitors that we can do? So we can monitor the intracranial pressure by directly putting a transducer inside the external ventricular drain. So that's the aggressive or the invasive way of measuring. So there are trials which have tried that, but the data is kind of limited and not so much widely variable. So the survival, because what are the reasons? The survival of patients with this advanced hepatic encephalopathy is not improved by ICP monitoring. So they don't know how much long-term information they give on the neurological sequel, and the putting the catheter itself can cause bleed in patients. So therefore, invasive methods of like EVD is not so much recommended. It is said that in these following scenarios, you can consider putting an EVD. Young patients with hyperacute kind of presentation, higher ammonia levels. I'll discuss the ammonia later. So ammonia, if it is very high, some studies suggest that it is associated with increased chance of intracranial hypertension and bleed. Renal impairment, vasopressor support you can. Because why vasopressor support? So that you have to mention a particular cerebral perfusion. When the ICP goes high, you have to keep the map higher so that you have a kind of a downward flow, or the flow towards the brain is maintained. So that's cerebral perfusion. Targets are, as I mentioned, ICP is less than 20 to a CPP of more than 50 to 60. Non-invasive, that's why, so when we know that invasive methods are not so much useful and they're associated with their risk, we can use non-invasive methods. So they are semi-invasive and absolutely non-invasive. Semi-invasive are reverse jugular venous oximetry. You put a specific catheter set there. We just like you put an IJ central line, we put it and then reverse the direction towards the jugular fossa. It measures the global oxygenation status of the brain, not so commonly used. What we can use is simple use of ultrasound. If we got a TCD, transcranial Doppler, we can put in the temporal fossa, we can monitor the middle cranial artery velocity, and we can monitor something known as pulsatility index. This is, I have not added this, but pulsatility index is a good marker of, or surrogate marker of ICP. If pulsatility index is more than, I think 2.4 or 2.5, the sum is the cutoff, it indicates that the patient is having an ICP. So there is a formula for it, 10.98 into pulsatility minus something. But so that's a usual technique. If you don't have a TCD, you can simply put a linear probe over the eyes and you can measure optic nerve sheath diameter. There is a technique is particular for this thing. The diameter, the cutoff is usually 0.6 centimeters. So if it is more than 0.6 centimeters, then definitely the ICP is elevated. But it is a kind of a dichotomous thing. If you have elevated, you call it raised ICP. If it is 0.45, 0.55, nobody knows. So it is a dichotomous thing, not so useful in acute setup, but it can be done nonetheless. Now, what is the predictive value of ammonia? This one is a very important slide. So this is taken from some previous papers where they mention arterial ammonia more than 120, 130 as per some papers 165. So mortality of 78.6% sensitivity, and with respect to mortality 77% or specificity. Now there are some do's and don'ts and some points to be discussed about the arterial ammonia. First of all, it has to be measured in the arterial blood, not the venous blood, because the once from the arterial system ammonia is generated, once the blood goes to the peripheral tissues like muscles, they get utilized, and because depending on the metabolism. So the arterial ammonia is the exact representation of what is the ammonia load. The venous ammonia is not. And if the venous ammonia is also high, definitely the patient is bound to have a higher ammonia levels. That is point number one. Point number two, as per the ASLD, arterial ammonia should not be measured to diagnose hepatic encephalopathy. Hepatic encephalopathy is a clinical diagnosis. So you are not measuring it for diagnosing. Secondly, can we monitor at arterial ammonia to look at various outcomes? Some studies have shown that arterial ammonia associated with increased chance of ICP, increased chance of intracerebral hemorrhage, worse outcomes. But there is a lot of false positive and false negative, meaning patients can have higher ammonia, but patients can do very well, come out of the ventilator, come out of coma. And on the other hand, patients having lowering of the ammonia but going into herniation, both of which have been seen very commonly, and I have seen myself. That's why there is the importance to ammonia should be just to have a kind of a rough guide, but do not put much focus on the ammonia solely to determine your outcome of liver failure. If the patient's coagulopathy is worsening, acidosis is worsening, even if the ammonia is improving, it is not a good thing. Patient is bad. So that is one take home point for ammonia levels. Otherwise, we measure it because it is used for one of the prognostic model, which I'll discuss later. Now coming to the management of hepatic encephalopathy. So other than the ammonia lowering therapies, which is obviously part of the management, as I said. So major thing is management of cerebral edema and intracranial hypertension. What are those? Head and elevation, minimal suctioning, or doing a suction with minimum stimuli, keeping oxygenation adequate, giving adequate or normoglycemia, do not allow hypercapnia, and allow normocapnia or mild hypocapnia in acute periods. Avoid the common factors that can increase the intracranial pressure, like frequent moving, valsalva position, suctioning at a very light plane, causing the patient to buck or cough, then using vasodilatory substances like nitroglycerin. So these are all, or severe hypoxemia, pain, acidosis. So that in a nutshell, when a patient comes, you have diagnosed hepatic encephalopathy, intubate the patient if the patient is having 3 and 4 encephalopathy, and knock the patient with adequate dose of sedatives and analgesics. If required, you can use a muscle relaxant, but that is not to be used always. So keep the patient sedated. Minimum amount of interruption or stimulation of the patient is what is recommended. Now coming to other factors are also important. So I probably not added this, but I'll just briefly discuss that factors such as constipation, hypokalemia, even hyponatremia, hypernatremia, all these things in an indirect way increases the glutamine synthesis activity in the muscles and peripheral tissues, increasing the ammonia and the glutamine levels in the blood. So if the patient is having an acute kidney injury, constipation, hypokalemia, these are all also contributory factors to an encephalopathy patient. Now, how will you manage? Hypertonic solution. So in INSL, that is Indian National Society, as I said, the guidelines they say that when we manage such patients in a peripheral setup, do not give hypotonic solutions. Always use normal saline or higher than that, or at least a plasma light, which has a sodium of 145. Do not use hypotonic solution. Point number one. So they particularly mentioned that do not use ringal lactate alone. If you're using ringal lactate, use it with a 3% saline to cover up the osmolality. Number two is that what do we use? Should we use mannitol or should we use hypertonic saline? As such, both are equal, but the INSL guidelines rightly recommends that use of hypertonic saline is slightly preferred because mannitol has its own way. It has got a somewhat delayed onset of action. Then it later on phase causes hypotension, diuresis, rebound kind of hypertension can occur. And what is more important is that you need a higher dose of mannitol to give, and that can cause increased osmolarity beyond 320, which is harmful. So that's why, and you don't monitor serum osmolarity always. So Practically saying, it is preferable to use hypertonic saline. Theoretically saying, both are okay. Now, the use of hypertonic saline and mannitol has to be done in the proper dosage and the duration. Use boluses. Do not use infusion. I keep on, telling this thing to many people who are unaware of the thing, that when you have a raised ICP, your osmolarity matters. If you're giving an infusion, it is going to take ever to increase the osmolarity. So always use boluses, and that can be at 3% saline bolus can be given over 15 to 20 minutes safely if you are monitoring serum sodium. So do not fear that there will be osmotic demyelination suddenly and all. Give an adequate dose of 3% saline, 200 to 250 ml TDS to QID is the dose. It's not 100 ml TDS. Similarly, for mannitol also, the dose is at least 0.5 to 1 gram per kg per dose. So a 20% mannitol bottle has to be given at least 175 to 200 ml per dose. It is not 100 ml TDS. So this dosing has to be given in a proper manner. As usually, we should monitor serum sodium 145 to 55 for this manner. Other than that, there are rescue strategies for ICP control. What are them? One is hyperventilation. So routine hyperventilation has got no role, but in periods where you think, okay, the BP is going up, bradycardia is occurring, patient is about to get coning, you increase the ventilation during that period. So it's the role of therapeutic hypocapnia or hyperventilation is to for temporary period, that is number one, not for prolonged period, and to reduce the cerebral blood flow for temporary duration to prevent the coning or the herniation. There is something known as therapeutic hypothermia, only head hypothermia. So you are not cooling the entire body, you are cooling the head. So that there is multiple proposed etiologies, that it can preserve the cerebral function, it can reduce the ammonia generation, but the drawbacks are also pretty much. Practically, I haven't seen anyone using this technique unless it is a really fallback option. And then again, you can use something like propofol or a pentobarbital coma if there is refractory raised ICP, seizures, and everything is going on. You can use that. Indomethacin, it can be used because it reduces the COX and the inflammatory mediators, but practically the use is less. So INSL recommends that grade 1 and 2 encephalopathy can be monitored. 3 and 4 require intubation. Prophylactically, we don't give any levera or any antiepileptic. But yes, if the patient has seizures, actively go for antiepileptic, monitor EEG throughout the day for absence of epileptic from discharges. They recommend that although benzodiazepines are harmful for hepatic encephalopathy, but short-acting benzodiazepines like midazolam is mentioned to be safe as per INSL. For sedation purpose, it can be given. There is no role of steroids, obviously. So now there is what are the other ammonia lowering methods? So the first one, which I should have mentioned, is renal replacement therapy. So in acute liver failure, the first and foremost thing which should be thought in mind to reduce ammonia level is renal replacement therapy. And among that, preferably a CRRT, continuous renal replacement therapy, rather than a PIRRT or an intermittent hemodialysis. Any form of extracorporeal therapy, be it CRRT, intermittent dialysis, or plasmapheresis, reduces the ammonia. But a prolonged therapy reduces the rebound of hyperammonemia immediately after the session. And that's why CRRT is better as compared to intermittent dialysis and all. There is some data that shows LOLA, that is L-ornithyl acyl and L-ornithyl phenylacetate can be used, but the mechanism is what? So this is the urea cycle. So what happens is that this LOLA and phenylacetate, they stimulate the urea cycle, and in that consumes the ammonia and produces more urea. Urea gets excreted in the urine. That's the basic funda of using the LOLA and all those. However, we have to remember that this LOLA is increasing the urea formation, by reducing the kind of ammonia in the body. The main mechanism is stimulation of glutaminase in the muscles, skeletal muscles. When the patient has pre-existing sarcopenia, lean and thin patient, LOLA will not work. And secondly, whatever amount of ammonia now it is now converted to urea and other things, they get back to the gut and blood and again gives rise to more ammonia. And that's why LOLA therapy is not so much useful, especially in ALF. Cirrhotic, some role is there. There is an upcoming role of sodium benzoate and phenylacetate. but the role has not. INSL mentions like they're undergoing the trials and all, but not so much promising. There is no role of rifaximin and lactulose in acute liver failure. Even if you're preparing a patient for acute liver failure for transplant, if you've given too much of lactulose or PEG for that purpose, you can have abdominal bloating, and that can hamper your process of acute liver transplantation. So do not use this. You can use it for constipation purpose. If the patient is constipated, you can use it, but do not give it for anti-ammoniacal measure. So now coming to Lola, as I said, so it has been found to be effective in ammonia, but Lola infusion does not lower ammonia levels or improve survival in ALF. The cause, as I said. So, in a nutshell, what are the different pillars of management of hepatic encephalopathy? So, manage the intracranial hypertension, manage the with 3% saline you have to give, manage, you can go for some amount of hypothermia, hyperventilation, you can go for hyperosmolar therapy, and you can simply follow the raised ICP triad, like that was followed in the SABIC guidelines of traumatic brain injury. You can follow the same thing here also. So initially normocarbia, normocapnia, get an APG done, head and elevation, and start osmotherapy as tier 2 approach. And in the last, you can go for therapeutic, IV sedation, pentobarbital, thiopentone, or propofol for that purpose. Now, coming to the second complication, that is infection. Very commonly seen in ALF patients. In the Western data, they say that the infection is there, but not so common. But the Indian data says that as much as 75 to 90% cases in ALF, there is some infection associated. There is a confusion regarding whether to treat the infection on day one. Most of the Indian trade centers, they prefer to use an antibiotic at the start because the epidemiology says that the majority of patients end up having an infection. And surprisingly, the amount of fungal infection is very high in among Indian cohort. So when an ALF patient comes on day one, a third generation cephalosporin, gram positives again depends on the hospital to hospital, not always means TICO or Vanco for that purpose, but many centers use a fungal antifungal agent, probably a fluconazole or an echinocandin at the beginning. It is depending on the epidemiological data. We have to remember that agents like caspofungin and fluconazole itself are hepatotoxic. So how much it is real time justified, I'm not sure. But as far as the Indian National Academy of Study of Liver Disease goes, it recommends using a prophylactic antibiotic at the along with probably an antifungal as per few centers. Why is there is infection? There is a decrease in the complement levels, neutrophil chemotaxis, there is opsonization defect, ROS, ROS activation, all these things causes a temporary immune suppression. So this one I have already discussed, that incidence is as high as 90%. Most common route of entry is the respiratory tract, followed by the urinary tract, could be blood as well. Now this is the why is there is infection. Again, the same thing. We have to mention one thing, that the gut microbiome or the changes of the gut microbiota is an upcoming concept, and it is very much prevalent that seen that many disease processes, including an acute liver failure, has a background of gut dysbiosis. So your gut modulation, gut microbiota, and fecal microbial transplants are coming up big way. So this is one important thing to add on to the previous things that I said. Now coming to the infection. So how would you suspect infection? So first of all, do not look at the search parameters, the tachycardia, tachypnea, all these things can be confabulated with an acute liver failure presentation. So if you have unexplained hypotension, unexplained hyperlactatemia, severe acidosis, probably you have to think about an infection. But definitely pointing is far-fetched, and that's why when the patient comes, send all the cultures and send the epidemiological surveillance cultures also if possible at the day one. So you know what we are probably dealing with. Antibiotic recommendation, as usual, as I said, European and Western data, they don't recommend an empirical or prophylactic antibiotic always, but Indian National Academy always recommend a prophylactic or empirical antibiotic at the start. Now coming to the next complication is renal failure. How much is the renal failure in this? First of all, this renal failure or the AKI is not hepatorenal syndrome. Hepatorenal syndrome is when we see along with a cirrhosis or CLD. Some say that hepatorenal syndrome type 4 can be called as ALF related, but the acute kidney injury and acute liver failure, in as per many hypotheses, it is part of the ALF disease process. the various toxins, the drugs that we give, the various inflammatory milieu that causes the ALF also damages the kidney. So the etiology is almost kind of an overlapping. Incidence is as high as 40 to 80%, and AKI per se increases the amount of mortality over and above that of ALF. So it is a very ominous sign. So ALF is very commonly noted with paracetamol poisoning, and that's why severe acidosis, hyperlactatemia is a danger signs as per the King's College criteria. So how will you manage the basics? Avoid nephrotoxic drugs, assess volume status, look at the IVC, look at the echo and the other parameters of perfusion, give adequate fluids, and again then you can have a dialysis. So if dialysis is required, so that is CRRT is as I said previously, it is definitely preferred in ALF, especially if there is hemodynamic compromise. And what if you are using a CRRT, you can use a CVPH or CVPHDF is slightly better. I'll not go to the individual discussion why. The CRRT removes ammonia from the body better than intermittent techniques in the long term. And the timing, the main important thing is timing. When will you start CRRT in a patient with ALF, and when you do whether to add an anticoagulation. So the timing is what INSL recommends is as soon as your AKI develops, and as we dialyze an AKI patient, dialyze in the same manner to ALF. However, studies have shown that CRRT starting in a bit earlier stage is somewhat helpful rather than going very late and starting as a dire measure when organ system severe acidosis is there or severe hyperkalemia is there. Other than that, if you start a bit early when organ systems or failure is progressing, probably is better. But there is no hard fast data on this. So this is the renal replacement therapy, as I said. So these are the hard indications where we do go for CRRT or any renal replacement therapy. Uremic complications, fluidovolar acidosis, hyperkalemia, severe dysesculating oligonuria. But as I said, CRRT should be initiated a bit early. Now coming to another important thing, coagulopathy. INR is not a reliable estimate of coagulopathy. It is an estimate of liver dysfunction. It is a rebalanced homeostasis. So on you have liver which produces a lot of coagulation factors, like all these factors from starting from 1 to 13, various factors except for factor 8, and some few factors are there which is not synthesized, and factor 4 obviously calcium. So other than that, all are synthesized from the liver. So when your factors liver dysfunction happens, the procoagulant factors reduces, but along with that the anticoagulation factors like protein CAs, all these things are also produced from liver, so they also reduce. What we measure via the test like PTI and APTT is the coagulation cascade, so they are what ought to be defective. We don't measure the anticoagulation cascade. So anticoagulation deficiency leads to a procoagulant status. So in a nutshell, in liver failure, majority of patients are homeostatic. They have a homeostasis. They don't have either coagulopathy or procoagulated status. They have a balance. And how can you, so there are various things that you can measure the factor 8, you can measure factor 5 to see the severity. And but in what we can do real time is doing a viscoelastic test for assessing the actual coagulopathy. We can do a rotational thromboelastometry or a thromboelastography tag, and that can decide on the transfusion. Another thing to be important that bleeding complications are not so common. Usually they are silent and mucosal bleed around the oral cavities, some mucosal bleed and all. Viscoelastic tests are recommended, as I said. So the different factors why there is coagulopathy and a procoagulant state both. So these are, as I mentioned, that there is coagulation factor reduced anticoagulation factors, increased tissue plasminogen activator, increased plasminogen activator inhibitors. So all these things causes a kind of a balanced kind of homeostasis. Now I'll come to the main things. So how does coagulopathy affect us? If the patient has an INR of 6, do not go for FFP prophylactically. So wait for the INR because that indicates how bad the liver is. Does not mean you should immediately go for FFP. So always transfuse if there is a bleeding. Secondly, if you are going for an invasive procedure, like for example, you are going for an invasive some procedure like some semi-invasive procedure like tracheostomy, you are putting a drain, INR is extremely delayed, which is life-saving. Patient is having some hemothorax. In those cases, probably giving an FFP is justified. Do not give prophylactic FFP. Target fibrinogen is more than 150 to 200. When will you give and how will you give? So even after giving FFP or fibrinogen is low, you can go for cryoprecipitate. Platelets not routinely given, only to be given if there is a bleeding and same indications. Now, what is the role of recombinant factor 7A? The dose usually is 4 units per kg, can be repeated after, I think, 8 hours. So recombinant factor 7 is an acute, hemostatic plug when the patient is bleeding. It can be given in patients with liver failure. Availability is an issue. But the major thing is that it cannot be given if there is a procoagulant state in the background, like the patient has a history of MI, DVT, you cannot give those. So not so commonly used, but it is one of the therapeutic, options. Transfusion threshold for hemoglobin, as usual, as in all ICU patients, is 7. Keep it above 7. Now, coming to hemodynamics, what happens in ALF is that you have a release of vasoactive mediators, lot of inflammatory markers which causes vasoplasia and low diastolic blood pressure. That's why you have a hyperdynamic circulation with increased cardiac output and low diastolic blood pressure. So you have to go for adequate crystalloid resuscitation. If you're using in a tertiary setup, do not go for resuscitation blindly. Always use your ultrasound parameters for resuscitation. Persistent increases in lactate is a bad sign because it indicates hypoperfusion as well as a bad liver function. Norepinephrine by default is a vasopressor of choice. Second vasopressor, INS will recommend sterlipressin, but I really doubt it. You can use vasopressin as well in a very low dose. It is very safe. You can use epinephrine also if you are not monitoring the lactate, or rather than you are not focused on the lactate. Coming to metabolic other things, hyponatremia management adequately should be done. Lactic acidosis, hypoglycemia. So liver failure patients on day 1, advise your nursing staff to check the sugar 2 hourly. Patients are highly likely to go into hypoglycemia. You have to give dextrose. If required, you can give dextrose infusion as well. And if the patient is or going into dialysis and CRRT, very high chance of hypophosphatemia as well. What is the role of nutrition? How will you give nutrition in these patients? So you have to give early enteral nutrition, and there is no role of protein restriction in these patients. That is the first and foremost thing. So you should start with a standard kind of thing like 20 to 25 kilocalorie per kg per day. But the idea is that during the ebb and the flow phase of nutrition, always better to start on the slower side on the initial few days and gradually build up nutrition. Probably by day 4 to 5, you can reach around 75 to 80% of what is required. Don't go for hyperfeeding in the initial, overfeeding in the initial period. So gradually built up. So these target calories are based on what is supposed to be achieved probably on day 4 to 5, not on the day 1. Protein not to be restricted. 1 to 1.5 is pretty safe. CRRT is going on, you can go a bit higher. But remember, more than 3 if you're giving, which obviously we don't give and we don't achieve also, that can itself cause encephalopathy. So, however, restrict what protein we use generally do not cause encephalopathy. It can be or rather should be given. And it's the usual route what we use for nutrition, that mode should be used. So nothing extra to be added. NG feeding is to be preferred. No preferential between NG and NG feeding. And in cases where it is required, there is no hard and fast rule of limiting the amount of lipids. So you can give the amount of permissible lipids in an ALF patient as well. Branch changed amino acid, not so much role. Probably in some cirrhosis, some role is there, but routinely branch change amino acid is not to be given, not definitely in ALF. So now coming to other metabolic parameters, as I said, it's the same things, all these sugars, the sodium, and hypokalemia, hypophosphatemia, hypomagnesemia has to be monitored. Respiratory, not so much to add. There is chance of acute lung injury, there is pneumonia, there is chance of pneumonia, there can be ARDS, and the main motto of respiratory thing has to be followed. So intubate if there is grade 3-4 encephalopathy, go for lung protective ventilation and prophylactic antibiotics and VAP prevention bundle. So these are the basic things. Now coming to another very, very important topic on ALF, that is NAC, N-acetylcysteine. What is NAC? NAC is an anti-inflammatory antioxidant. It provides a sulfityl group. Why? Because in ALF patients, especially because of acetaminophen or paracetamol poisoning, the sulfityl group of glutathione is depleted. We want to add more sulfityl group or help in regeneration of the glutathione moieties so that it helps in subsequent generation of glutathione in the liver, and then detoxification. The thing is, NAC is always, the few things has to be mentioned, that it is classically used in a paracetamol liver failure, but in non-paracetamol cases and paracetamol liver failure, there is a mortality benefit. So it is definitely has to be given. Whereas in non-acetaminophen usage, like non-acetaminophen induced ALF, everywhere we are using a NAC infusion. So it has been shown that there is some amount of transplant-free survival is increased. Per se, mortality does not change, but transplant-free survival is increased. It is not a very costly drug, and so that's why, considering the risk and benefit, NAC in an acute liver failure, we don't know the cost, prefer to use it. Now there are oral dosing, IV dosing. Oral dosing is 140 mg per kg loading and then some 70 mg per kg 4 hourly. We don't use the oral dosing much. We use the IV dosing. IV dosing is 150 followed by 50 and 100. So the 150 mg per kg loading over 1 hour, then 50 mg per kg over 4 hours, 100 mg per kg over rest 16 hours. There is a lot of variations through this protocol. The usual simple way to remember is that if you have a 60 kg man, 936 rule. So 9 gram loading, then 3 gram over 4 hours, 6 gram over next 16 hours, completes 1 plus 4 plus 16, that is 21 hour. This is called as a 21-hour protocol. But right now, we are also okay with a 72-hour protocol where the 100 mg per kg dose is continued for 24 hours. So roughly 6 grams over 24 hours. So we can write 936 and 6 continue every day. When to stop? Generally, when the liver enzymes come down to a less than probably a kind of permissible level of less than 500. Exactly, I don't know the any value is there or not, but 72-hour protocol is like that. So this is the role of NAC, as I said, in non-acetaminophen ALF. It has shown that greater transplant-free survival is there. So this one important term has to be remembered. Coming to some tidbits about acetaminophen liver failure, usually seen if there is an ingestion of more than 10 grams at least and a single setting. Some predisposed individuals like chronic alcoholics and all, they are highly, or malnourished patients, other hepatotropic or hepatotoxic drugs are given. So then paracetamol causes an acute liver failure very significantly. Usually it's a suicidal ingestion. Peak absorption occurs after 4 hours. And when the liver failure stage in, it's actually quite late. So initially you have an asymptomatic phase. After 6 to 12 hours, you get some transaminitis, some liver dysfunction, vomiting, nausea. But when it is 72 hours and beyond, you have the peak. So you have to act immediately. And that, how would you act immediately? Using a modified rheumatoid methanomogram, where you plot the paracetamol drug concentration in the serum with respect to time. And if it is above the particular set of level, you have to act immediately with NAC infusion. So as I said, there are some situations where the toxicity chances goes up. Then there comes to other important issues like hepatitis. So hepatitis A per se, there are some role of IVIG, some role of plasmapheresis, but per se symptomatic management is to be done. For hepatitis B, some say that the anti-hepatitis B therapy can be initiated, but the exact guidelines is a bit different. Hepatitis E, ribavirin has been tried, but again, not so much of data. Coming to ALF in pregnancy, we have to think about an acute fatty liver pregnancy. That means the patient has to get terminated pregnancy immediately, or you can have a HELP syndrome. These are the two major possibilities. And in pregnancy, hepatitis E is the most commonest cause of ALF in patients in India, Indian patients. Now coming to another important topic, prognostic models. What prognostic models we use for ALF in prognostication? So first and foremost, we have the King's College criteria for acetaminophen, the modified King's College criteria of the same acetaminophen, and non-acetaminophen poisoning. So I will tell you the basic one trick for remembering. So King's College criteria can be remembered as PHC, primary health care. So P stands for PT of more than 100 seconds with INR more than 6.4. H stands for hepatic encephalopathy, grade 3 or 4, and C stands for creatinine, more than 3.4. That's the original King's College criteria. Modified one includes that if it is lactate 3.5 even after 4 hours of after 4 hours of admission or severe acidosis, or lactates more than 3 after 12 hours of administration fluid, it is also a significant sign. So to underline, acidosis is significant bad predictor of outcome in the patient as a paracetamol poisoning. And you have, as I mentioned, creatinine, the paracetamol causes AKI as well, especially ATN. So creatinine is also has to be high. Non-acetaminophen, if you get PT of more than 100 as a single criteria or any three of the following, it can be remembered as A, B, C, D, E. A for age, less than 10 or more than 40. B for bilirubin of more than 17.5. C for presence of coagulopathy, D for particular drugs or non and non-B hepatitis, idiosyncratic drugs causing it, and E for encephalopathy. So if you are having an icterus to encephalopathy duration is more than 7 days, that is having a bad outcome. So if you are having a hyperacute or fulminant, for example, less than 7 days presentation, it is good outcome. A subacute, like a mostly seen in drug-induced AKLF like ATT, it is having a bad outcome. Clichy's criteria takes into account the factor 5 levels with respect to age. Factor 5 below a certain limit indicates bad prognosis. Model for end-stage liver disease score is mostly used for listing for transplant, not so in ALF patients. However, for again prognostication, it has got its role. So it can be used. Coming to another thing to remember, just look at this phosphate. So phosphate, if it is high, it is a bad thing. But in a patient who has a liver dysfunction, if phosphate is low, mostly indicates a good thing because it indicates the liver cells are regenerating, they're taking up the phosphate from the serum. So coming to the shortcomings of the system, none of them are very perfect. None of them are actually tailored to a Indian setup, and that's why different therapies and the acute need and the dynamicity is not taken into account. And that's why we have something known as the early dynamic model of liver failure, the ALFED score, which was prescribed by the Amazonians, the AIMS people, who said that the 4 parameters has to be taken into account: hepatic encephalopathy, INR, bilirubin, and ammonia. And this is a dynamic test. It has to be checked at baseline and at 48 hours. Failure to failure to resolve these issues by 48 hours means the patient is going to in a bad direction. And how does it help? If it is more than 4 to 6, indicates that patient is mostly requiring transplant. So it is a prognostic model, and also by 48 hours it gives you an indication whether the patient is likely to be going up for a transplant. And it is very important that when you are managing an ALF patient, if you have a transplant setup nearby, you think that the patient is going for a transplant, immediately refer to the patient. Because if you lose time, the patient is going to lose life. So the advantage of ALFED model is dynamicity, better performance with respect to Indian setup, good AUROC, and the recent there are multiple data. I have not been able to cover up those, which says that ALFED is better than most of the scoring system with respect to ALF. Even ACOG also recommends, ACOG also has some data in AC that shows that. So coming to the other last few topics, that is therapeutic measures like liver transplant. So liver transplant, it is to be done in a liver transplant setup like Apollo has. If you have a patient who is likely to be requiring transplant, immediately send the patient for transplant listing. And the contraindication for transplant are obviously a patient who is brain dead, severe infection, and if there is severe more than 3 multi-organ failure, probably not a good idea to go for transplant. There are 3 types of transplant. One is that disease donor transplant. Patient gets lucky, there is a patient who is dying and then or dead. From that, you take the disease donor and you transplant. Second is live donor transplant. Very difficult to date in our setup because patients' relatives don't hesitate a bit, hesitate more than enough to agree to giving their part of the liver, although it is a very safe thing, but they don't give. So there is an option known as auxiliary partial orthoptic transplant, which I came to know about recently, that it is that the native liver is cut, part of the native liver is cut, part of the native liver remains, and part of the graft is kept over there. So the graft, which is small as compared to the native liver, acts just to support the liver or the body for some days. And as the patient improves, the native liver, once disease free, grows back. It is especially useful for children. Now, coming to extracorporeal therapies, the last few slides of today's discussion is that what are those? One is what are the methods? I'll just briefly touch upon them. One is high volume plasma exchange, basically plasmapheresis. High volume, why? Because the molecular size of the inflammatory mediators in ALF is quite huge, in the range of 20 to 30 kilodaltons and above. You need larger membrane pores. So when you are using a plasmapheresis, you want to use a high flux membrane and a session lasting for 4 to 5 days at least, with particular target of 35-40 mL per kg per hour, mLs per kg. So that should be the target. So it helps in removal of the cytokines, helps in the removal of the ammonia as well. So high volume plasma exchange, the role is there. There are some data which say that plasmapheresis even has a better transplant-free survival, but INSL recommends not to use it without the pretext of transplant. So if you're going for transplant, probably you can use it. Again, there is another data which says that no, it is not a good idea to go for plex before transplant. Again, conflicting, not a established mode, but currently there is a lot of data coming up, especially in case control studies where high volume plasma exchange has been used in ALF as well as in ACLF patients. And coming to the major disadvantage is that again coagulopathy, hypotension, and hypophosphatemia. If those things are not there, plasmapheresis can be done. So, as INSL says, plasmapheresis can be considered to increase survival for non-transplant patients. Coming to the other things is liver assist device. Personally, I have never seen any because I have never been able to look at how they function and all. This is all theoretical to me as well. So there are cell-based device systems and there are non-cell. Cell-based device, so they will have detox function as well as synthetic functions. So cell-based device systems are hepatist, ELAD, extracorporeal life acid support, and bioartificial liver system. And the artificial non-cell based are some methods by which you just remove the toxins. So namely they are MERS, molecular absorbent reticular system, and Prometheus, which is fractionated plasma separation and absorption, and single pass albumin dialysis, SPAD. So this is the basic difference. Artificial ones, they will remove the toxins causing detox. Bioartificial ones will have synthetic as well as detox function. This is the pictorial representation of molecular absorbent reticular system. So this is the patient, it's just like a dialysis machine, just you are using a dialysis machine like a normal way, except for the part that the dialysate has to go through multiple resins in order to get detox themselves. So this is the patient circuit, this is an albumin circuit, and the albumin after getting all the toxin products from the patient goes into the anion exchange resins and detoxifies. So you're using a lesser amount of albumin. Whereas the single pass albumin dialysis is one technique where using a high flux dialysis membrane where you are using continuous albumin. So the albumin is taking the toxin from the patient's body and getting removed. So you have to continuously give a high amount of albumin, so the cost goes up. Prometheus again is a fractionated plasma separation technique where you have to use a special filter through which the particular cytotoxic materials are removed and they are meant to go through a particular set of resin. So how to use that? There are some data which suggests that extracorporeal life support can be helpful in terms of reducing the transplant-free survival, but with respect to our country's consideration, that available LADs fail to make an impact as a bridge to transplant or improve trial survival. So nobody really knows exactly how to use or how to hear. Probably, obviously, hepatologists like Dr. Akash will have a better say on this. So nature of therapy, heterogeneous population, transplant listing. So it is difficult to make a guideline on liver assist device, although it can be used, but difficult to make a guideline. These are some highlights of the INSL 2020 guidelines with respect to the therapies. I have already mentioned that, and this is one do's and don'ts that is mentioned in that particular that INSL guideline. You can go and have a read. I've already mentioned maximum of them. If something is remaining, you can look it up. This is another topic. I would like to skip that because I intentionally added it. This is one topic of post-operative liver transplant. Liver transplant has occurred, and day 3, day 4, patient has undergone some complication, and you see that the patient is having an ALF. In how to approach those patients. So there are some vascular causes which can cause. Just I will name a few. So there are graft dysfunction and vascular causes. So graft dysfunction and primary non-function, early graft rejection, and vascular causes like hepatic artery thrombosis, stenosis, portal vein thrombosis. These are all some causes in the perioperative period. That's it. I'll not go to the discussion of how to go in individual of them. That concludes my presentation. Anybody has any doubt or any query, you can ask.
Hello, sir. Sir, we also have some
Hello.
question in the chat box.
Yeah, yeah, yeah.
I would
Yeah.
also request
Okay.
Dr.
Can
Akash Roy
you?
to please take the question.
Okay, thank you, Dr. Abhishek. It was very well covered, very detailed. I'll just add into some points as I was hearing through your talk, which would be an add-ons. First, I just realized I think we need to update our nasal guidelines. I think it's high time we update them, and because there's a lot of new evidence that has come in, so we would be looking at putting it. I'll just have because I think this is mostly for residents and trainees who are there as part of their training. Just 2 minutes on some important things that you need to remember. and then we take on the questions. I think we have around 5 minutes to discuss this. See, etiology is very important. See, first thing that you have to remember is mortality with acute liver failure 10 years back used to be upwards of 70%. It's just the reverse right now. We are achieving success rates without transplant. About 70% of them are all surviving. And that's because of good standardized investigative management and identification of etiology fast. The most important thing I want to communicate specifically to the Indian audience is that today hepatitis A is undoubtedly the most common cause of acute liver failure in adults. It's no more in pediatrics. It's an adult disease. People are dying left, right, and center out of hepatitis A. And this is an outbreak we need to concern with. Mostly, you get some fractions which are autoimmune hepatitis. There is a small role of steroids in this patient. If you get patients with acute liver failure in early stage of hepatic encephalopathy, grade 1 and 2, there the best chance without a transplant is possibly use some dose of steroids, and there's a recommendation also to use it. I really liked it that you mentioned the that do not go ahead using lactulose and rifaximin. I see it every day in consults that anybody with any liver disease gets tons of lactulose thrown in and gets ammonia ordered 5 times, God knows why. On irrespective, people with renal failure getting ammonia as orders. What do you expect with renal failures? Ammonia has to be high only. What else you will get? So, very importantly, lactulose has actually not been shown to be beneficial in acute liver failure. But I put a big but into this. That's it. Doing trials in acute liver failure is very difficult. Number one, the incidence of the disease is low. You do not get sufficient amount of patients, and to achieve a power for achieving mortality benefits is very difficult. So it's very difficult to do a 300 patient trial for the acute liver failure. So what the only thing is that though there has been no proven benefit with lactulose, we should not be also giving the information or communication to our audience that do not use lactulose. You can use lactulose. Lactulose definitely lowers ammonia, but do not try to put that patient on 6 enemas of lactulose or like 4 times bowel washes, because that leads to hypernatremia. That leads to a lot of gas and bloating, as you were mentioning, which is a big problem. Similar with rifaximin, I think rifaximin should not be a part, but again, we don't have a good quality randomized trial. I think there are two important things that we need to add into what was there. See, the INASL guidelines in 2020, I think that was when Professor Anand had made it. Our data with CRRT was still not good. Even today, there is hardly one randomized trial, one systematic review based about of 4 retrospective studies. One of is our center study and a multicentric Indian study that we last published. So today we do not use CRRT only if you have got AKI. So, or you have got uremia setting. The consensus today globally is to go in as early as possible, possibly 12 hours to 24 hours. Because our experience with using CRRT has become so better, and it's a safe modality, hemodynamics are well maintained, that we would be looking at, say, the patient comes into you, you get a baseline ammonia, you see a sky high ammonia, you wait and see how the dynamics are, how the lactates are moving. Within the next 6 to 12 hours, you get your lines ready and it's on CRRT. So that's one thing. And second is plasma exchange. The European data with plasma exchange is actually all about high volume plasma exchange. We have sort of stopped doing high volume plasma exchange altogether. I think Dr. Raki's unit at ILBS, their trial is actually not high volume plasma exchange. It's standard volume plasma exchange. There are units which do low volume. Our unit does standard volume because we have burnt our hands doing high volume plasma exchange, because plasma exchange, it's going to take out everything. It's like an all or none phenomena. It's going to take out your pro-inflammatory cytokines, it's going to take out your anti-inflammatory cytokines, and that leads to a problem. So we have tried to, and the volume fluxes that it causes a lot of hemodynamic shifts. Those hemodynamic shifts are something which is terrible for any of these patients to work with. So though the Europeans still have this concept of using high volume, we have got at least 2 trials coming out with standard volume. We have got a very good European data which actually showed what your side effects with high volume plasma exchange is. This was just published this year. So we need to take plasma exchange with some degree of caution. Wilson's disease plasma exchange is something very, very different. People tend to confuse the Wilson's disease plasma exchange with standard plasma exchange. But again, we need to adjust it into the settings. And the last part is the prognostic scores, uh, be it Alfred, be it King's College, be it CPI. See, these scores were actually made in an era which is a little bit back. Today, you get a patient with acute liver failure coming in, you will have your lines in, you'll have your plasmas transfused because you want to have those lines in. They will be A on plasma exchange, B on CRRT. All your prognostic indices will actually go for a toss because most of them have INR. You do a line, you're going to autocorrect your INR right there. You're going to put a CRRT line, you will have to transfuse. Nobody's going to do a CRRT line for you without correcting it. So your INR is gone. Some scores have creatinine. You put the patient on CRRT, the creatinine will automatically go down. Ammonia will definitely reduce with whatever measures you're going to use. So we need evolution of these measures. And as I really liked it when you said and pointed it out, a persistent hyperlactitemia or a persistent acidosis is a very, very, very good indicator that this patient is not going to do well. And these decisions are actually within the 12 to 24 hours. So the bottom line message to anybody who sees acute liver failure patients is that transplant should always be in your mind, that if anything is going wrong, this patient needs to be in a transplant. If your unit is skilled at managing acute liver failure, be cautious and keep on managing it. But if you are not confident or you're not used to having managed acute liver failure, get to your closest unit which is good at it and be there, because the 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 difference between dying of acute liver failure and making it out without a transplant is just this much. Little bit of issues here and there, you've got to lose the patient. But a fantastic comprehensive talk that you summarized all so much with so much details, and was, I think, very beneficial for all the residents. I'll Dr. Abhishek will just take up a couple of questions and try to round up in about 5 minutes from here. Um, I think you have touched upon most
Thank you
of
so
them
much.
in your you have touched upon most of them while you were delving on it. You have touched upon NAC in acute liver failure in non-paracetamol as uh, so there is something about so there was something about anticoagulation, which I think is interesting. Role of high volume plasma exchange, we discussed it. Dr. Roy has told you that high volume was initially brought in with the study by Vin Larson. After that, we have got data with standard volume and then again with low volume. I like this question on anticoagulation because this is something which needs to be addressed. It's not much with plasma exchange because plasma exchange is a short procedure. When you have CRRT, you've got a problem with the circuits clotting, off and on, off and on. So, and there's a wide debate. People don't want to use anticoagulation in patients with liver disease for the fear of citrate toxicity and heparin, obviously, because you are thinking that it's going to cause. So, what's your take? I have been I discuss it out with my nephrologist that you take the risk for the citrates, I'll take the risk for the toxicity.
So, as far as the theory is concerned, it is said that in citrate, regional citrate anticoagulation can be administered, but
Absolutely.
again, if it is severe acidosis and severely reduced liver or diminished liver function, then giving regional anticoagulation also is problematic. And
Right.
if systemic has to be given, heparin can be given theoretically, but again, there are chance of bleeding. Some say that half dose heparin also is many trials it has been used. But I would suggest that because considering the filtered life and everything, if you're monitoring the patient's calcium levels and total calcium and everything closely, regional citrate anticoagulation is a good choice if the patient is on CRRT.
Right. Absolutely. And I do agree with you, RCA. And I think we need to move ahead and get more used to using RCAs in all our liver failures, not only acute liver failure, but also in acute and chronic who are on dialysis. There's a question on dengue with liver failure, low platelet count, 10,000 liver transplantation can be done. I'll take this. See, You can do. There are have been reports of liver transplantation for dengue ALF. It is an indication, but you should remember that dengue liver failure usually comes with a lot of additive problems. You frequently tend to have them land up in HLH. Any secondary HLH, if you transplant them, your chances of recurrent HLH in the graft is high. Plus, you have got other organ dysfunctions which may not improve with transplant. It has been done, it has been successful, but it needs to be decided on a case to case basis. There's a question on it says better to choose terlipressin over noradrenaline in DCAD. And this is not related to our talk, right? Incidence of hepatoadrenal syndrome in acute renal failure. I think we wanted to put it liver failure, right? So again, hepatoadrenal syndrome is not something which you'll be seeing, which you'll be more concerned with acute liver failure. This is very something very commonly we see in cirrhosis. Patients who are there with cirrhosis, they frequently have relative adrenal insufficiency, which is again very difficult to diagnose because the cutoffs are very variable and you don't have the standardized cutoffs to do the test because cortisol has got you need lipids to form it. So it's basic cholesterol structure. That cholesterol is usually synthesized in your liver. So those tests are not validated, but definitely there are studies which have shown that the incidence is very high. Actually, it can go up to 30% also. Uh, can we give soda bicarb in severe acidosis? You're a critical care person. I know the controversies with soda bicarb. We always
It's
vouch for
a
this that it has got no effect, but we all land up giving it somewhere time or the other.
Yeah, I mean, it's for severe life-threatening acidosis only we can give. The cutoff is somewhere, some say 6.9, some say 7, but more than 7.1, definitely routine bicarbonate administration doesn't have role. It's a different topic altogether. I mean, giving bicarb, whether
I
8.4
agree.
is an adequate dose or half to 4.2 is an adequate dose, and then again, based on the how much renal dysfunction patient is having. So, in a nutshell, it's not a straightforward answer. If there is life-threatening acidosis, severe hyperkalemia going into arrest, give it routinely. Otherwise, if the patient is on CRRT, then that can be managed. The bicarbonate level can be managed on that. So we don't need to give bicarb per se.
Very true, and I agree with you on this. I think there is very specific where you're maybe tiding over a very critical crisis, uh, getting everything ready. That may be the only area which you're going to be using it as. Uh, Advancements of hepatoprotective therapies in targeted cytokine modulation. Yes, there is some role of targeted cytokine modulation. You mentioned about Mars. There's a new machine called Dialive which is coming out of a company called Yakrit in UK. So that's for ACLF, not for acute liver failure. It might have some role in acute liver failure, but again, ALF, the timing is either going to be this way or that way in the 48 to 72 hours. So it's difficult to put in. But till now, again, as he said, we viewed FSPA as they used in ILBS unit. We have seen MARS being used. None of them really work that well. My experience with none of them have been that well. Till today, what's given good results is early CRRT and plasma exchange to some extent. Emergency liver transplant for a patient. Yeah, so this is always there. So this is your first line treatment. You should always be ready for it if your medical management doesn't work. Tips. This is not related to the current discussion of sinistral portal hypertension. So I think this I think can wrap up after we take this. This is about managing cerebral edema. He has mentioned everything. I think everything in details was mentioned. Fluid management for resuscitation. Dr. Avishek, you want to take this as to see this is again a challenging situation when you've got initial
This
resuscitation.
is So I think resuscitation initial period we can go ahead with the initial resuscitation fluid of somewhere around 10 ml per kg odd, but we have to always check with our dynamic parameters. So in critical ill patient we always check with our pulse pressure variation, or we have a cardiac output monitor that can be checked. But there are some drawbacks with a particular CLD, acute liver failure or CLD patient is that the use of non-calibrated systems like flow track and all are having our drawbacks. So pulmonary catheter again is not recommended. So better to always look at the kind of a trend of every parameters. Do a PLR, passive leg raise test, to assess for the fluid responsiveness. If fluid responsiveness is there, we can go for some fluid resuscitation. And we have to always apply the ROSE concept with respect to fluid, the resuscitation, optimization, stabilization, and evacuation. So do not flood the patient at the after 2 to 3 days. If the patient is having significant positive balance, don't flood the patient. Probably a positive balance in day 1 or day 2 is kind of okay. And use ultrasound to decide on what amount of fluid to be given. And if you are using a single fluid, do not use ringalactate or hypotonic solution. If you are using along with 3% saline, probably you can use any fluid. That's my tip.
Absolutely, absolutely. I think again, there's some personalization in fluid management that needs to be done. I think we have overshot time to some extent, and uh, thank you, Dr. Abhishek. Thank you to the entire First
Thank you,
Academy.
sir.
I think this was a very, very well taken lecture, and I think you have made everything very crystal clear about acute liver failure. Thank you, everyone.
Great
Thank you,
information.
sir. It was a very nice session, very informative. Thank you, Abhishek, sir. Thank you, Akash, sir. And thank you to all the aspirants present here.